Hello, good evening, friends. In this video, I will be teaching about non-tubercular mycobacterium, covering the introduction, classification, clinical presentation, laboratory diagnosis, treatment, and an applied exercise. So, there are currently around 199 species of non-tubercular mycobacterium, which are mostly isolated from environmental sources like soil and water. We have to remember some of the predisposing factors in host and in environment which are leading to non-tubercular mycobacterium like pre-existing lung diseases, immunodeficiencies, and exposure to swimming pool water, soil dust, tap water, etc. Now, Mycobacterium are broadly classified as Mycobacterium tuberculosis complex, Mycobacterium leprae, and atypical mycobacteria or non-tubercular mycobacteria. Always we should remember that Mycobacterium bovis, Africanum, Microti, Capre, Pinnipedi, Canetti, Suricate, and Origis are also coming under Mycobacterium tuberculosis complex and not get confused them as atypical mycobacterium. So there is one important classification for atypical mycobacterium, that is Runyon's classification. So Runyon's classification is based on the growth of NTM on solid culture media. So if it takes more than 7 days to grow, they are called as slow growers. And if they take less than or equal to 7 days, called as rapid growers. So slow growers are further classified as photochromogens, scotochromogens, and non-photochromogens. Photochromogens, that is, they produce pigment. In the name itself, it is there. Photo means light, chrome means color. So they produce pigment on exposure to light. Scotochromogens, they produce pigment both in dark and on exposure to light. Non-photochromogens, they do not produce pigment even after exposure to light and also in dark. Now, there are some mnemonics which I have made to remember photochromogens. That is, photo means sunlight. Okay, get it in association with gas crisis that is going on. So, if we do not have gas, we cannot run kilometers. So, remember, photochromogens mnemonic is gas kilometer. Why sunlight? That is, if we have gas crisis, then the option is to shift to solar system. That is why sunlight. So G for Genevans, A for Asiaticum, S for Simiae, K for Kansasi, M for Marinum. For scotochromogens, I gave mnemonic as SSG. Remember another project running for gas crisis, that is use of natural gas mixture with liquid gas running underneath the ground and connecting to each house as SSG. So S for scrofulaceum, another S for sulgai, G for gordone. Now, mnemonic for rapid growers. Rapid means they grow fast. So remember them as fast kilone. One more thing is kilone means toy. So toy also moves faster. So the species coming under them are F for Mycobacterium fortunatum, A for abscessus, another S for smegmatis, and S for Simiae, and lastly Mycobacterium kilone. Then I could not find any interesting mnemonic for non-photochromogens, but I have given the mnemonic as MACPUX. Remember them as Mycobacterium avium complex, P for Mycobacterium paratuberculosis, U for ulcerans, X for xenop. Now, regarding clinical presentation. So they can cause localized clinical disease or disseminated disease. In localized, they cause pulmonary infections, lymphadenopathy, or skin and soft tissue infections. So, as already mentioned, the most common cause of pulmonary infections are Mycobacterium avium complex, followed by Kansasi. For lymphadenopathy, again Mycobacterium avium complex, followed by Kansasi. For skin and soft tissue infections, remember some of the rapid growers, ulcerans and marina. Then also remember that the symptoms are similar to tuberculosis. So there can be slow progressive fatigue along with cough with expectoration, etc. So there is a criteria for diagnosis, that is clinical criteria with microbiological criteria. So what comes under clinical criteria? Either there will be symptoms, okay? So the symptoms may be pulmonary, or if it is affecting lymph nodes and skin and soft tissue, those symptoms. Or there will be some radiological evidence, and also there is exclusion of other diagnosis. In microbiological criteria, if it is pulmonary infection, there is either of this, that is culture positivity for at least two separate sputum sample, culture positivity for at least one bronchial aspirate. So either of that. If bronchial aspirate sample is there, which is superior sample for lower respiratory tract infection, so one sample which shows positivity will be enough. Now, for extrapulmonary infections like lymphadenopathy, skin and soft tissue infection, or dissemination, there should be one smear positivity and one culture positivity. Smear positivity can be histopathological smear positivity, ZN, fluorescent microscopy, either of that. Plus a culture positivity should be there. Coming to laboratory diagnosis, always start with sample collection, as you know. So in pulmonary symptoms, if pulmonary symptoms are there, sputum, ball will be the sample. If extrapulmonary, lymph node aspirate, pus or exudate, biopsy from skin lesion. If it is disseminated, blood bone marrow biopsy will be the sample. Now, microscopy comes first, as you know. Direct microscopy comes first, that is ZN staining or fluorescent microscopy, or if histopathological staining is done, that. With that, gene expert. So gene expert will help to differentiate non-tubercular mycobacteria with Mycobacteria tuberculosis complex. So Mycobacterium tuberculosis complex will show positivity for CB-NAT, whereas NTM will be negative for CB-NAT because there is absence of gene that detects the NTM in CB-NAT. Coming to culture, remember we can use solid media like LJ media, okay? And it has to be incubated both in light and dark. Then other culture medias are there, automated like MB Bactech, Middlebrook, and Midget for culture and sensitivity. Acid fast staining should also be done from culture once the growth will be there. Then there is one rapid immunochromatographic test which also can differentiate MTB complex from NTM, that is MPT 64. MPT 64 test which is positive and it is specific for MTB complex. Now remember LJ media, Mycobacterium tuberculosis produce rough, tough and buff type of colonies. Non-tubercular mycobacteria, exactly opposite, it produces smooth, moist, easily emulsifiable colonies on LJ media. So you have to remember LJ media is a egg-based media. It contains malachite green. That's why it appears green, and also glycerol. Okay, malachite green will inhibit other contaminants, other bacteria that can grow, which may be contaminant. And Mycobacterium tuberculosis or NTM having mycolic acid will resist malachite green and grow in the LJ media, and this media is sterilized by inspisation method. You can see what is the smooth pigmented colony on LJ media and which one is rough, tough and buff colonies. Now, recently, because of automated method, that is MALDI-TOF, which is based on ribosomal proteins, the diagnosis of NTM has become much more easier. And other molecular methods used for diagnosis are like GenoScholar, which is WHO approved and contains both NTM and MDR-TB. Then in PCR, if we are looking, the specific gene is HSP65 gene. Then coming to the discussion about important NTMs, that is, remember Mycobacterium marinum. So marinum means you will remember water, right? So remember them in association with swimming pool granuloma. So they produce granulomas. So what you are seeing here is picture of swimming pool granuloma. Lesions appear from days to weeks, okay, after inoculation. Usually, if the person is having some scratch or some minor injury, then there is chances of getting swimming pool granuloma after exposure to Mycobacterium marinum. So these are the complications and the treatment is clarithromycin plus rifampicin and clarithromycin plus ethambutol for 3 to 4 months. Moving on to next one, that is Mycobacterium kansasi. So this was example for which classification? So if you can recall, I had told you gas kilometer, K for Kansas. So going back to photochromogen. So it is one of the photochromogen. Then I had also mentioned that most common cause for pulmonary infection is MAC followed by Kansasi. So remember, it can cause chronic pulmonary disease. It can also cause lymphadenopathy. So you can see the symptoms are mostly resembling tuberculosis. Then lab diagnosis, it is a photochromogen, produces brilliant yellow colonies which is nitrate positive and also rapidly positive for twin hydrolysis. And the recommended regimen is use of HRE, that is isoniazid rifampicin and ethambutol for 18 months with at least 12 months of negative sputum culture. So that is 3 times the culture sensitivity has to be negative. Then comes another important species, that is Mycobacterium avium intracellular complex. So in this, important species are Mycobacterium avium and Mycobacterium intracellular along with other members. So if they cause disseminated disease, usually it is due to Mycobacterium avium. Respiratory infections are usually due to Mycobacterium intracellular. And this MAC infection is very important opportunistic pathogen in HIV infected people with low CD4 count, that is less than 50. Remember, these are the infections caused by MAC, that is in patients with bronchiectasis and cystic fibrosis, because of impaired mucociliary clearance, it favors persistence of infection of MAC. Dissemination is seen in liver, spleen, and bone marrow, into liver, spleen, and bone marrow. And also, it starts by GIT, that is phagocytosis by macrophages, which gets converted to foamy macrophages, gets disseminated all over. Whenever it is getting disseminated, it is called as MAC disease. Otherwise, they cause pulmonary disease. Okay. Pulmonary disease, it has various presentation. Either it can have diffuse pulmonary infiltrates, it can have tuberculosis like cavities, it can show nodular bronchiectasis, or it can just show resembling neoplasm like solitary pulmonary nodule. These are the various presentation, and the picture here shows isolation of MAC on smear, that is from lymph node biopsy. Then MAC disease, as already told, when it gets disseminated, especially in HIV AIDS, it causes MAC disease. So there will be various clinical features like high fever, night sweats, chills, weight loss, abdominal pain, diarrhea, leukopenia, hepatosplenomegaly, etc. Always remember, I had told you in HIV patients, CD4 count less than 50, they are more prone for MAC disease. So here are some of the revision. Solid media. On solid media, it takes around 35 days. Which is that solid media? LJ media. Yes, you are right. LJ media. Liquid media is Middlebrook media. It takes around 10 to 21 days. Mild it off can differentiate two species, that is Mycobacterium avium and Mycobacterium intracellular. Treatment here will be RIA regimen. R for rifampicin, E for ethambutol, A for azithromycin. Again given for 18 months and minimum 12 months after culture conversion. And for prophylaxis, the treatment used is azithromycin, that is 1200 mg weekly, or rifabutin 300 mg daily. As mentioned, AIDS patient with CD4 count less than 50, they are more prone for MAC disease. So, prophylaxis is mandatory, and what can be given is either azithromycin or rifabutin. Then I am also discussing another infection which is called as Buruli ulcer. So here the causative agent is Mycobacterium ulcerans. Which classification it belongs to? It belongs to, yes, you are right, non-photochromogen. So non-photochromogen, the mnemonic was PUX, in which MACPUX, in which U stands for ulcerans. Here also it initially produced nodule, then plaque, then diffuse edema. It can also cause necrotizing fasciitis. So necrotizing fasciitis causing bacteria is which one? Yes, you are right. That is group A Streptococcus. Now coming to last important topic, that is rapid growers. So rapid growers are isolated from hospital outbreaks, from foot spot disease. Most commonly it was caused by Mycobacterium fortuitum. Remember F for foot spot disease, F for fortuitum. It was isolated from injection site abscesses, post-traumatic wound infections, tattooing associated surgical site infections. That what was isolated was Mycobacterium chelonae, disseminated cutaneous infections, pulmonary infections, that is in case of patients having cystic fibrosis. So wherever I have put dash, that is for you to recall and fill that. So the treatment in case of pulmonary is amikacin plus cefoxitin for 2 to 6 weeks, followed by cot plus doxycycline for 6 to 12 months. In case of skin and soft tissue, It is doxycycline plus cod for 4 to 6 months. Remember this, according to CD4 count, which are the opportunistic infections. It is important, so I have put here. So, when the CD4 count is 500, patients are prone for HZV. And when it is less than 200, that is herpes zoster. When it is less than 200, they are prone for cryptosporidium, microsporidium, miliary TB, esophageal candidiasis, pneumocystis, girovese. When CD4 count less than 100, cerebral toxoplasmosis and cryptococcal meningitis, both CNS. When CD4 count is less than 50, they are prone for MAC disease, that is disseminated MAC infection, CMV retinitis. So this is for your revision, which is the classification for NTM, that is Runyon's classification. Which are the species present in MTB complex? So try to again revise which are the other species other than Mycobacterium tuberculosis. Some of them are like Mycobacterium cannati, Mycobacterium africanum, etc. You can revise them. Criteria for diagnosis is one is clinical criteria, one is microbiological criteria. In clinical criteria, symptoms, radiological evidence, and ruling out of other diseases. In microbiological, you have for pulmonary, for extrapulmonary. For pulmonary, there should be two sputum sample positive for culture if it is sputum sample. If it is BAL, one culture positivity will be enough. For extrapulmonary, one smear positivity and one culture positivity. Modalities of lab diagnosis. So you have you have direct microscopy, culture and sensitivity, automated and molecular diagnosis methods. Most common NTM causing pulmonary disease. Already you know Mycobacterium avium complex. How to treat skin and soft tissue infection caused by rapid growers, as already mentioned in the last slide. That is, in case of pulmonary, you will treat with amikacin plus cefoxitin for 2 to 6 weeks, followed by cod plus doxycycline for 6 to 12 months. In case of skin and soft tissue infection, doxycycline plus cod for 4 to 6 months. How then coming to applied exercise? So as you can see here, the exercise, it is HIV positive patient. Patient has pulmonary infection symptom and chest x-ray is showing lingular infiltrate, CD4 count 150 cells, sputum positive but gene expert for MTB, that is CBNAT negative. So it is most probably one of the most common infection, especially occurring in immunodeficient patients. So it could be an NTM, mostly Mycobacterium avium complex. So this is all about NTM or atypical mycobacterium. If you have any doubts or any clarifications, any suggestions, please type in the comment box. Then please follow and subscribe my videos and encourage me for teaching furthermore different topics. Please give your valuable feedback. Thank you.